Okay, so clock is 5 o'clock Eastern European time, and we are ready to begin. So welcome everybody to this Disior Webinar session entitled The Future of Clinical Research and Practice of Hand and Wrist. My name is Eero Waris. I'm working here at Disior with product development, and we will be having an interesting session today, with the timeline being roughly as seen on the screen. First, I will give you a very brief introduction on the two companies organizing this webinar, as well as a brief view on the Disior product and analysis offered by our company. After which we get three interesting presentations from top of their field surgeons, and after which we have time for some questions and discussion. I will introduce the actual presenters after this introductory section. So if we go straight into the point, most of the themes to be discussed today, they revolve in one way or another. They are relying on the modern developments of medical imaging modalities. So because of that, we are very happy to have with us PlanMed, who helped also organize this webinar. They have available Verity CBCT, cone-beam computed tomography scanner, which is especially suitable for extremity imaging, and it has some nice specifications which you can read here. And even more importantly, it includes some advanced three-dimensional features, 3D processing features, as well as a nice integration to Disior bone logic analysis workflow. And I will now describe what that is for those of you who might have not heard of it. So Disior analysis software is a medical image analysis tool, which can take data from CBCT scanners such as Verity, which I mentioned, but also regular CT devices, as long as as the data is in standard DICOM format. What the user is required to do, he or she selects the bones they wish to include in their analysis, after which everything else is automated. Sorry. Which yields then a full segmentation of the whole wrist complex, so each bone individually, as well as certain measurements which characterize this anatomy. So we have, for example, here a longitudinal axis of the radius bone, as well as some landmarks automatically found by the software. And based on these, we produce different kind of measurements, radiographical parameters, which are in here. You see a few examples of those. So on the top row, you see volar tilt and ulnar variance. And in the bottom row, you see some carpal alignment angles between radius, lunate, scaphoid, and capitate bone, if I'm correct. And also, additionally, the user might use software to study different joints. So one can visually see with color mapping the joint gaps. We can see where the bones might be impinging or where the gaps might be widening. And then, as an upcoming feature, we are now currently working and finalizing our virtual surgical planning features. In here, we have an example where we have collapsed distal radius, and using our tool, one can define an osteotomy line and then just virtually correct or adjust the positioning. And what is nice, I mentioned the radiographical parameters, which the software is automatically computing. You can see in real time how they are affected by the virtual operation you are performing. So you can aim for example, normal values, or you might want to aim for the values taken from the contralateral side of the anatomy, and so on. So this is in very brief format some of the analysis capabilities which are already existing there, for example, in our Disior software. And we feel these are very interesting and important advances in technology. But what is, of course, most important is how potential end users of the software, as well clinicians at large, how they can utilize these kind of possibilities then in their both medical research and clinical practice. So for this end, we have scheduled 3 excellent presentations by people shown here in this slide. We have from Kantonsspital Baselland in Switzerland, Dr. Philipp Honigmann, who will be talking about modern tools for clinical decision-making and treatment, as well as from HUS University Hospital in Helsinki, Finland. We have Dr. Eero Waris, who will be discussing about 4D wrist kinematics. And then from Arcademy Hospital in Sweden, we have Dr. Elisabet Hagert, who will be then talking about clinical application of CBCT kinematic analysis in a complex wrist case. So taking this in a way similar concepts as Dr. Waris, and then using them at an actual clinical patient case. And a few words about the practicalities of today. We have you should be using the GoToWebinar app or a tool which includes some sections, and you should be able to find a section for questions. And we welcome you to, throughout the presentations, just send any questions you might have for the presenters in that section. At the end of the whole session, so after these 3 presentations, we will go through as many of those questions our time allows. And also during a few of the presentations, we will have a couple of polls, which means you will get a prompt to choose between a couple of options. So you are welcome to contribute to that as well. Right now, I think we are ready to start with Dr. Honigmann's presentation, which is, I believe, going to discuss about at least 3D printing and digital preoperative planning and these kind of possibilities. And it sounds very exciting. Looking forward to hear about that. Now I'm going to switch the presentership. Just a second. Dr. Honigmann, please.
Hello and good afternoon, everybody, and welcome to this exciting webinar with some excellent speakers on my side. I'm very happy to join this webinar today. I'm talking about modern tools for clinical decision-making and treatment, and this is just an overview of my speech, a short warming up with an introduction. Then I jump to general aspects of image acquisition, and then I will show you some cases with modern assessment of distal radius fractures, distal radius malunions, and scaphoid non-unions. So let's start in 1980, where Hideo Kodama first rapid prototyped something. He did a 3D planning and then printed something. But unfortunately, the patent did not go to him. It went to Chuck Hall, who printed his first part in 1983. And for that, he got the patent, and for that, he is mentioned in the National Inventors Hall of Fame. And he is the founder of one of the oldest 3D printing company in the world, 3D Systems. So let's continue with the Hall of Fame of 3D printing and planning in hand surgery. it is rather old. Some first mentioned were in 1988 by Bilic, followed by Jupiter, Athwal, Oka, and Andy Schweitzer in 2009. On the left-hand side, you can see a digital planning in black and white or gray. On the right-hand side and middle, these are some pictures out of the publication of Oka, who did an intra-articular corrective osteotomy using a and then on radius. And this is where we are now. In 2020, we had a growth of 7.5% in 2020 of the production of additively manufactured part from independent service providers. This is a value of about $13 billion US, and 11% of all of this is in the medical and dental field, as you can see on the right-hand side. In 2021, we are printing and planning in the hospital at the point of care. This is something we wanted to achieve, and this is something we want to continue to do research on. And this has just recently happened next to the place where I'm sitting at the moment, in the University Hospital of Basel, where we start to print PEEK implants in the or next to the OR. This is the future, and I think this should be continued. What do you think, audience? This is a vote you should please be part of. Is this a hype or hope? According to the Gardner's hype cycle, there is an innovation trigger, a peak of inflated expectations, a trough of disillusionment, slope of enlightenment, and plateau of productivity. So you get now the chance to vote between those 5 points. I think the poll is open. We have like 20 seconds to wait for the first results. Then Eero will present the results. So I can show them, I hope so.
Do you see the answers?
Can you see the answers?
Yes, we have 37% at innovation trigger, and then 17% at the next step, the peak of inflated expectations. Only 3% at trough of disillusionment, and then 27% at slope of enlightenment. So it's a few of them. Few of our audience members seem to be at the earlier steps, and then a few on the later steps. But
thank you for your votes, and please wait for the next poll then. So I will continue with general aspects of image acquisition. This is rather important. Of course, we have the two opportunities to get some DICOM images using CBCT, cone beam CT scan, or multi-sliced CT scans. I just presented here the two opportunities with the dosages, and there are some more information in the publications mentioned down there. It's rather easy in the daily routine to use the CBCT scan. But one has to know how the position of the wrist is towards taking the pictures. In the Verity CT or most cone beam CT scanners, the hand is in pronated position, and this has to be taken into account when planning anything like 3D assisted osteotomies, because just as a reminder, On the left-hand side, this is the neutral position, which should be used when acquiring images for 3D purposes. And on the right-hand side, you can see the different positions of the ulna related to the radius as the radius moves around the ulna. And there are also some aspects which one needs to know. There are, of course, those different techniques, but there are artifacts because of foreign materials, motion artifacts, motion blur. There are different kernels. As you can see down there on the right-hand side, the U is a more soft one versus the V90 is a more harder one. But it's still hard to define the borders between cartilage and bone, as you see in this zoom. Where exactly is the border of the bone and where exactly is the border of the cartilage. So this is sometimes the difference between 1 and 2 millimeters. That's rather important when planning. So let's start with some modern assessments. This is the assessment of the distal radius fracture. We have a 43-year-old female who felt on ice on her left wrist. These are the pictures we usually get in those two planes. And then the analysis starts with the multi-slice CT scan. We have those different planes, the axial, coronal, and sagittal view, to understand and trying to characterize the fracture. But also, I recommend to always use these 3D virtual models to play around with and assess the fracture lines, assess the characteristic of the fracture and understand what to do and make up the plan. And this is the view on the articular surface with the different fracture lines. The software enables us to get some automated measurements. As you can see, this is the same fracture with the ulnar variance, volatile, radial ulnar inclination, and the radial height, just directly out of the software to help to make up a decision. And recently we started with automated fracture line detection to have a try to see whether we are able to have a full automated process on assessment of the fractures. So this is the achievement so far, because what we want to do, we want to go for fracture-specific fixation. The goal is, as shown, the automated fracture identification, then identify the key fragments. I like the four-corner concept of Brink and Wrigley because it shows which type and which fragments are the key fragments and what you have to do. And then the next step would be the full automated reposition of the fragments. And then one has to aim for the best fixation with standard implants. And maybe there's a need of patient-specific implants, as we recently have seen in many presentations. But there's a history behind those patient-specific implants. It's rather old. It's from the group of Amsterdam, around Ivan Dobe, Simon Strake, and Gert Steekstra. They published in 2013 about the design of a patient-specific distal radius implant to correct an osteo, to correct a malunion. And they kept on publishing on this topic, and you need to consider some key points. You have to know which are the key fragments, the biomechanical units, which kind of approach do you want to use, the volar dorsal approach, and where do you want to have your screws placed for optimal support regarding load, shear, and bending forces. And if you need a patient-specific implant, which kind of design. And I really encourage you to read this publication by Giuliana Caiti, Biomechanical Consideration in the Design of Patient-Specific Fixation Plates for the Distal Radius. It shows that it rather needs some very good placed screw rather than too many screws. They will do the job as seen in the picture down there, labeled number D or D. So this is what we did in the case we used the standard implant to fix this fracture. We didn't use any patient-specific distal radius plate. So let's continue with the distal radius malunion assessment. We have a 72-year-old patient who had a malunion of, or malfixation of the distal radius fracture, and he was referred to us. These were the pictures we got with the patient, and we thought of maybe we do normal X-rays again, or directly go for a CBCT scan and analyze the data in the software. So this is the analysis in the software. The DICOM images were directly imported, and as you can see, the metal is segmented very well. With the distance mapping, you can clearly have a view what is the problem. So the distal radius is malunited. There is an overload of the sigmoid notch in the dorsal aspect. Of course, this is in pronation, but it's more overload on the dorsal aspect of the sigmoid notch. And one can, of course, criticize that we are not able to adjust any alignment of the carpal bones, but this is rather easy with the software and this translucent just to go back, you can also see the results of the measurement. Back to the model, it is measured here, and there's of course like an ulnar plus, but it's the problem which is on the dorsal aspect of the distal radius. So according to these values, we planned a corrective osteotomy and fixed it with the standard plate, and the patient as well. That was the 6 weeks follow-up. The next case is a little bit more complicated. It's a 28-year-old patient who had a multi-level corrective osteotomy of the radius after a malunited radius fracture 10 years ago. He had a pain-free interval, and then he developed ulnar carpal pain and a lack of supination of about 20 degrees. On the left side, you can see the plate still in from the corrective osteotomy 10 years ago. And on the right-hand side, these are the actual, this is the actual situation this year. So the patient was referred to us, and we did what everybody does, planning 3D using the healthy mirrored site. And according to these values, we had to correct the radius of about 15 degrees clockwise in an axial plane, like 4 degrees, 3.5 degrees volally in the sagittal plane, about 1.2 degrees. This is debatable if it's really necessary, in an ulnarly and a coronal plane. And we assessed that it is an ulnar plus of 1 millimeter. So again, it's on you now. What shall we do? Shall we do a corrective osteotomy of the distal radius according to the values? Shall we do an ulnar shortening, further investigation, or do nothing? The poll is open. So it's like half and half at the moment. 48% go for the corrective osteotomy according to the values, and ulnar shortening 8%, and 38% would do further investigation. So this is what we did. That was our approach. We planned virtually a corrective osteotomy of the distal radius according to the values, using a standard plate and designing a osteotomy guide for the corrective osteotomy. But at this point, we thought, is this the correct intervention we are doing? And we had a look again on the data we had, and we realized that there is a difference between the position of the ulna in the sigmoid notch. And then we would want to quantify what we have planned. On the left-hand side, you can see the mirrored right side, the mirrored opposite side with the distance mapping. In the middle, that's the preoperative left side. You can see that the distance here, there's a distance here in the ulnar head, which we already measured. And on the right-hand side, it's the virtual osteotomy, which we planned, the 40.7 degrees rotation. And we would have done exactly the wrong. We would have overloaded the dorsal aspect of the sigmoid notch, doing the distal radius osteotomy. So what we did finally, we did a derotation and a shortening of the ulna using patient-specific guides and a standard plate. And this is the intraoperative view. The derotation was done by these guides. We corrected it by about 5 degrees. And you can see on the right-hand side that the ulna is a little bit shorter, but it's also hard to assess whether the ulnar head is really good centered. This is the 6-week post-operative view. The normal X-rays on the left-hand side, and then the 3D reconstruction out of the CT scan, but it's hard to quantify. So we did the distance mapping again. You already know the pictures on the left-hand side, and also the two on the right-hand side. The second from the right, it would be the wrong osteotomy, and on the right-hand side, it's the results 6 weeks post-operatively. So the ulnar head is quite well centered in the sigmoid notch, and it's a little bit more shortened. So, and the patient is well. So that's the last topic, the scaphoid non-union assessment, modern ways to treat with this pathology. We have the cone beam CT scans of a 47-year-old patient who has a long history of this malunion and also some degenerative problems already on the radius. And this is the way it goes normally. DICOM data, you go for segmentation out of this using the data, and then for 3D model to have a view how the situation exactly is. And based on these data, we did an automatic non-union detection. So this is the detection of the line, and then a virtual resection of the non-union. And the next step would be the automated reposition of the scaphoid according to the contralateral side, for example. This is what we normally do. On the left-hand side, you can see the situation of the non-union, and you can clearly see with this distance mapping why this degenerative changes on the radius happened, because there's an overload here. And on the right-hand side, this is the mirrored contralateral side in the affected side for the planning of the reconstruction. And for reconstruction, we use the technique described by Häferli and Schumacher and also by Andreas Schweitzer. It's apparently the same. You enter K-wires, and once the K-wires are parallelized, then the design or the situation is according to the contralateral side. And then, of course, you need the guides to place the K-wires in the situation where it is. And then you need to have another guide to hold those K-wires in parallel. This is the planning of our patient, 47-year-old patient. On the upper left side, you can see the planning and the mirrored contralateral side inside the planning. And according to these values, we designed the guide to place the K-wires. And on the lower aspect of the image, you can see the situation with the K-wire parallelized, and then on the right lower side, the guides to hold the whole scaphoid open. These are the intraoperative pictures. The K-wires inserted, then parallelized, and then it's easy to have a graft, rather vascularized or non-vascularized, whatever your choice is. and then fixed it with the screw. And this is the assessment 6 weeks after. In the software, you can see that there is no more overload at the radius styloid. And just to show you the reconstruction with distance mapping, there's a homogeneous color of the surface of the scaphoid to the capitate. And this is the last slide, an intraoperative view of the guides we used. For another case, this guide is made of 2 pieces to easier remove them. And this is to show how easy it is. The whole situation is open. The scaphoid non-union is resected and ready to implant the bone graft. And I want to thank you for your attention, and I especially want to thank Eero Waris, who is responsible for all the videos and all the analysis I have shown. Thank you very much for your tremendous work, Eero.
Thank you for the kind words, and also obviously thank you for the very interesting presentation. I'm sure our audience has lots of great questions. I remind everyone to send them in via the questions section, and then we will go through them at the end of the session, and you might direct them straight to Dr. Honigmann or have more general comments along these topics as well, whichever you prefer. And next up, after this very thorough and impressive description of the three-dimensional phenomena, we now move to the fourth by having Dr. Eero Waris here discussing about 4D wrist kinematics. I'm assigning presentership to you, just a second. And here you go. Dr. Waris, please.
Thank you. Can you confirm that you can see me and my presentation?
Yes, we see and hear you. Yes.
Thank you. Okay, good afternoon, everybody. Greetings from Helsinki. I'm Eero Waris, a hand surgeon from Helsinki, and I will tell in this presentation about our research project concerning the computer-aided analysis of wrist kinematics. My conflicts of interest are presented here. I'm working at the Department of Hand Surgery in Helsinki University Hospital and also in Mehiläinen Hospital in Helsinki. And I'm also a partner in Disior company. We have several projects going on concerning the computer-aided analysis of wrist CT images, and in this context, I will tell about our studies concerning the computer-aided dynamic CT image analysis and how we are able to analyze quantitatively the carpal bone motions in vivo using Disior software. These preliminary results presented here are based on great work made by Dr. Teresa Höglund. Our research team is listed here, and we have had a great collaboration with both Disior and PlanMed. A few words about wrist kinematics. It's a very complex one, as you all know. The wrist consists of distal radius and distal ulna, which articulate with 8 small carpal bones. The motion of each of those carpal bone involves multiplanar rotation and translation, and its understanding is clinically important because several traumatic and degenerative wrist disorders may affect it. Especially in so-called dynamic wrist instabilities, carpal misalignment may occur only during wrist movement or under wrist loading. And that's why the analysis of wrist kinematics is important in clinical practice. the problem is that the current diagnostic tools and the use of traditional imaging techniques, they are limited when we are assessing carpal kinematics in patients. Fluoroscopy and kinefluorography, they have been used to visualize carpal kinematics, but their interpretation is limited to two-dimensional view. MRI and CT, of course, they provide a 3D image, but for example, MRI has poor spatial resolution, and the long acquisition time in MRI is not optimal for dynamic imaging. The radiation dose of traditional multi-slice CT limits its use, especially if we need CT scan with serial images to visualize kinematics. Also, the positioning of the wrist is challenging when we are using traditional MRI and CT, as already Dr. Honigmann told us. Quite often when we are using these traditional imaging devices, we have to force the wrist in pronation, which is not optimal always for when we are imaging wrist. Cone beam CT is a relatively new technology for extremity imaging, and in our clinic, CBCT have almost totally replaced traditional multi-slice CT scan in the wrist and in the hand area. Its major advantages are high spatial resolution, relatively low radiation dose, and the free positioning of the patient and the wrist while performing the scan. As seen in the lower picture here, the wrist can be imaged in neutral rotation using Planet CBCT device because of the small size of the device. The effective radiation dose of the wrist CBCT is about 2.4 microsievert, which is equal to about 2 to 3 plane X-rays. And when compared to multi-slice CT, the dose is significantly lower. In cooperation with Disior and Planet, we have now developed computer-aided wrist dynamic CT imaging for quantitative analysis of wrist kinematics. In the first stage, we developed the method, and we have now analyzed quantitatively the carpal bone motion of asymptomatic wrist of healthy volunteers. And the aim of this study was to investigate quantitatively the carpal bone kinematics during isolated wrist flexion extension and isolated radial ulnar deviation. So for this study, we imaged 64 asymptomatic wrists using Planet CBCT device in wrist neutral rotation, and each wrist was imaged in 7 standardized positions using a special hinge tray, which you can see here in the picture. First, we imaged the wrist in neutral position, then in 30 degrees of flexion, maximum flexion, and then 30 degrees of extension and maximum extension using this hinge tray. And after that, the wrist was also imaged in maximum ulnar deviation and maximum radial deviation. With the Disior software based on segmentation of the CBCT images, 3D model of each wrist in various positions were interpolated digitally, creating a kinematic model of the moving wrist. And these two videos show the flexion extension movement of the wrist in 2 views, in sagittal plane and in coronal plane. So this flexion extension movement was interpolated digitally from 5 different positions. First in maximum extension, like now, and then 30 degrees of extension, neutral position, 30 degrees of flexion and maximum flexion. If you look at those videos accurately, you can see very small steps in the motion between those interpolated 5 wrist positions. And then accordingly, we also reconstructed isolated wrist deviation, and this motion was interpolated from 3 standard position, from maximum ulnar deviation like now, then neutral and maximum radial deviation. In these videos, you can see that the software has determined the bone axis for each bone. The red line is for radius, green line is for scaphoid, orange one for lunate, light green for capitate, and purple for the third metacarpal bone, and so on. Geometric axis was used for radius, capitate, scaphoid, and the third metacarpal bone, and for other carpal bones, articular surface normals were used as bone axis. And using these axes, we were able to analyze quantitatively the kinematic data and changes in the carpal bone alignment. Radius was set as a coordinate, and in the left figure you can see the change of carpal alignment in sagittal plane during the isolated wrist flexion extension motion. So in this left figure, the x-axis describes the flexion extension of the third metacarpal bone compared to radius. And then in the y-axis, the alignment of each carpal bone is described during this wrist movement. For example, you can see the scaphoid alignment here in the green line, which is the uppermost line, and then this red line is lunate, and the capitate bone is the purple one. In these figures, you can see the range of motion of each carpal joint space during wrist motion. For example, in the left figure, you can see the red line represent the radiolunate joint, green line is the capitolunate joint, and the purple line is the third metacarpal, the third carpometacarpal joint. For example, in this left figure, you can see that the portion of radiolunate and lunocapitate joint movement of the whole wrist flexion extension movement is equal. However, in maximum extension, the radiotriquetral joint, this blue line here, moves about 30% more than these radiolunate and lunocapitate joints. And the CNC joint, which is here, is almost, it doesn't move at all, except in maximum extension. There's a few, maybe 5 degrees of flexion. And on this right figure, you can see how the proximal carpal row, so lunate and triquetrum here, they deviate ulnarly, and then lunocapitate joints deviates radially, resulting finally in poor isolated flexion extension movement of the whole wrist. So those 2 joints, they compensate each other. The software also makes possible to analyze the rotation and translation of each carpal bones. And these figures demonstrate the rotation of each carpal bone around sagittal, coronal, and axial axis. And these 3 figures demonstrate the translation of each carpal bone in these three planes. We are also able to analyze the joint spaces during this wrist motion. Scapholunate instability is one of the most common wrist instabilities, and these three figures shows the distance mapping of the SL joint space of healthy wrist in neutral wrist position in the middle, and then also in maximum extension and maximum flexion. And this data of healthy wrist may help us to analyze dynamic SL instabilities in the future. So in conclusion, using computer-aided dynamic CBCT, it's possible to analyze quantitatively carpal kinematics, and based on our studies of healthy volunteers, we have now reference values for normal carpal bone kinematics. I think this technique has potential as a new diagnostic tool for wrist kinematic disorders, but of course we need further studies. At the moment we are running new studies to examine the kinematics of various wrist instabilities. Hopefully this provides new data of kinematic wrist disorders and may help us to diagnose and treat those challenging disorders better in the future. And finally, royal blinking here. Thank you for your attention.
Thank you very much, Dr. Waris, for this very insightful presentation. And I think we have now, as a nice next step, we saw this kinematics research advances, and now we see possibly how they could be utilized also in the clinical theater then at an actual patient care. And for that, I invite Dr. Elisabet Hagert to have her presentations. Just a second. Here we go. Please.
Hello, everyone. It's a pleasure to be here this afternoon. And let me get my screen shared. And can you please confirm that you can both hear me and see my screen?
Yes and yes.
Perfect. Thank you very much. Well, this will bring you to a very clinical and hands-on experience of using CBCT after all the excellent presentations by Eero Waris and Philipp. My disclosure is that my clinic, Arcademy, has a key opinion leader agreement with PlanMed. So we use the PlanMed Verity point of care extremity CT scanner to provide high quality 3D CBCT scans. And in our unit, we're using it for hand and wrist, forearm and elbow, as well as for foot and ankle. And with regard to the foot and ankle, you can use it either unloaded or for loaded imagery of the entire foot and ankle joint. This is my office, and you can see that I have a bunch of screens, and to the right I have my ultrasound machine, which is a Canon i800, and the combination of being able to do CBCT scans as well as ultrasound diagnostics on my patients has resulted in the fact that I very rarely send my patients to an MRI, because I get a complete analysis of the skeletal and cartilage injuries using the CBCT scans and the soft tissues using ultrasound. So what are the key points when it comes to using a cone beam computed tomography? Well, it's easy to use. In our unit, the surgeon, him or herself, does the entire examination. It entails low radiation. It has a 30-second examination time. We use it to evaluate, for instance, fractures, as in this, a volar lip fracture of the distal radius. We use it with intra-articular contrast in the joint to evaluate possible ligament tears. Here, for instance, you can see a TFCC tear and a central disc rupture causing extravasation of articular contrast into the DRUJ. And you can also evaluate osteoarthritis or chondral injuries in the joint, as the CBCT goes all the way down to 0.2 millimeters, which makes it possible to evaluate even chondral injuries in the wrist joint. Well, I would like to share with you a difficult clinical case that I'm struggling with at the moment. This is a case of a male patient who is right-hand dominant. He used to be a motorsport practitioner doing something that we call enduro. He had his first wrist injury in 2014 of his left wrist. He was operated for a scapholunate ligament injury in 2015. In 2016, he was reoperated with a scapholunate ligament reconstruction. In 2018, a third wrist surgery was performed where one did a four-corner fusion. In 2019, a CT scan was done, and you can see the rotating image right there. And that CT scan showed that the scaphoid was remaining. For some reason, it was not removed at that first surgery, that first four-corner fusion. The screw placement was, for instance, in the lunar-triquetral joint and not in the lunate itself. The screws that were placed in the lunate were fractured, and there was this pseudoarthrosis of the four-corner fusion. So based on this, a fourth wrist surgery was performed in 2019. At this surgery, the scaphoid was removed. There was bone grafting done into this prior pseudoarthrosis area. A new implant was in place. And then now, 2021, the patient was referred to me. He came to me because he had diffuse radial and ulnar-sided wrist pain, and he had mainly pain upon loading, no pain at rest or at night. And so I took some CBCT scans in our clinic, and this is what I found. In some parts of the images, it looks like the four-corner fusion has healed completely. Whereas in some parts, it looks like there might be a non-union or a pseudoarthrosis. So to investigate this further, we wanted to see if there was actual motion in the four-corner fusion indicative of a non-union as a cause of wrist pain in this patient. So we used the device that Dr. Waris showed before, with the wrist placed in a neutral position in the CBCT scan, in a flexion position, as well as in an extension position. This is what the various CBCT scans look like. So to the left, you see neutral, in the middle, you see flexion, and to the right, you see extension. I sent all of these images to Disior for further analysis. And what we found was that the range of motion in the analysis performed was from 23 degrees of flexion to a total of 45 degrees of extension. Within this range, in a normal and a healthy wrist, you will have rotation between 30 to 40 degrees between the capitate and the hamate, and as well as the lunate. Whereas in a fused condition, you should have no variation, you should have no motion, because those joints should be fused together. Well, if we look at this particular case, you can see that, for instance, in the capitolunate angle, when you compare the neutral position and the flexion position, you have a 9-degree difference in motion. And in the lunar triquetral angle, if you move from the neutral to the extended position, we have a 12-degree difference. We also did a rotation and translation study, also like Dr. Waris showed. And what we found was that we had both rotation and translation occurring between the lunate and the other carpal bones that were supposed to be fused together, the triquetrum, hamate, and the capitate. We can do a motion animation. In this particular motion animation, you can, in the left image, see the lateral view between the capitate and the lunate, and in the right image, the anterior view. And so what you're seeing is, as we're moving the wrist from flexion all the way up to extension, we see that there is a motion occurring between these two carpal bones. So it means that we have now a 28-year-old male. This male has gone through 4 prior wrist surgeries. He has gone through 2 failed four-corner fusions. He has pain upon loading. And so the question is, what should we do? So let's have a poll. Should we do nothing, leave it as it is? Should we do a new four-corner fusion using some other form of fixation, a new bone graft? Should we do a total wrist fusion or a total wrist arthroplasty, for instance, the Motec total wrist arthroplasty? So let's have a poll and see what you would like to do in this case. All right, we're having some extremely interesting results here. The poll is now closed. We are seeing that 52% would do a new four-corner fusion with other fixation technique. 24% would do a total wrist fusion, 14% a total wrist arthroplasty, and 10% would leave it as it is. Well, how are we reasoning around this? Let's see, can we leave the poll and move back to the slides?
The slide should be showing now.
Thank you very much. I'm sorry, I'm not getting the slides to be showing again. Can you try again, Eero? I'm not getting my slides to show again.
We are seeing them in the audience view at least. Do you have dual monitor system? Just a second, let's try.
Oh, now you get to see my beautiful dog instead. Okay, let's see. All right, now we can advance. Okay, so nothing. Of course, you can do nothing. It's in a way the easiest thing to do. However, the patient has pain and it's a young patient. Total wrist fusion is always a very, very safe option because you know that the total wrist fusion will heal and it will give a pain-free result. However, it's quite a major surgery, and this is quite a young patient. So to completely fuse a patient that is only 28 years old might be a little drastic. The total wrist arthroplasty is something that we really like to do in our unit. However, there is concern with regard to the survival rate of the implant. Once again, since this patient is only 28 years old, there's a risk that the implant might only survive about 10 years, and then you will have to do a wrist fusion. So what we are planning to do is, as 52% of you voted for, it's not ideal, but we're thinking that it's likely the only real option at this stage. We will open it up, perform a complete degradation of the joints, bone from the iliac crest, and a more solid fixation with cannulated screws. So a difficult case, but I think it illustrates very nicely how the kinematic analysis using the CBCT scan is an excellent way to give you answers in difficult wrist cases. So thank you very much.
Thank you, Dr. Hagert, for this excellent presentation. We have 1 minute left in our schedule, but I think we can go a couple of minutes overtime to have a view on the audience questions. And for this, I will invite all presenters of today to turn on their cameras and microphones. I will very quickly. Okay, Ignacio Garcia Fleury did send some questions to Dr. Honigmann, but they have been already answered. So I think you can, if you are interested, you can view them in the questions section. I have a couple of other questions that I would be happy to hear and some insight upon. So if maybe we can go in, and also if you still have something, of course, for Dr. Hagert or Dr. Waris, or comments in general, please just put them into the questions section still, and I will look at that a bit later. But before that, I would like to ask Dr. Honigmann. It was very interesting and impressive to see you have this peak printing capabilities already there. It's from what I know, it's quite a difficult material to process, so it's quite limited amount of printers which actually can create that kind of engineering grade polymer parts. So do you think using that, will you still be needing titanium implants, or maybe do you have any in any case need for patient-specific metal parts?
Yeah, I think in general there is need of patient-specific implants. It's not a hype. To go back to my poll, I think it's a part of hope, and we use titanium because we are in the area here. There are companies who use titanium, and they are well equipped working with titanium. But we also want to explore the polymers, and of course there's PEEK being the next polymer. It is one technology to use a 3D printer, but it doesn't have to be. The final result is important, that it is a sustainable and weight-bearing patient-specific implant who can articulate with cartilage, and this is very difficult. And the surface needs to be very well polished to articulate with cartilage. And I think PEEK is a good option also.
Yeah, thank you. And from Dr. Waris, it was very interesting presentation as well. I was curious about, from what I know about the subject, that those this kind of motion, they might get very complex at how to actually represent that kind of phenomena. So you mentioned that you use this kind of coordinate system which is fixed on the radius bone. So do you think that is best way to describe all kind of motions, or do you think there's a need, for example, to maybe fix everything relative, for example, to the proximal row of the wrist and so on? I will okay. Yeah.
Okay. It of course depends what do you want to know. I think the radius is a good coordinate, but for example, if you want to compare the motion between scaphoid and lunate, or lunate and capitate, it may be easier or more demonstrative to compare the motion to lunate, for example.
Yeah, thank you. We just got new question. Maybe this is for Dr. Hagert. So Ignacio Garcia Fleury is asking, is the decision on a new fifth four-corner fusion based on the patient being young and active? Would this change on an older, less active patient?
I think that is an excellent question, and certainly one that is to the point. I would choose a different type of surgical technique in an older patient. My first choice would most likely be a total wrist arthroplasty, for instance, the Motec implant. If I had a patient who had, for some reason, could not receive the total wrist arthroplasty, I would go for the total wrist fusion. But the arthroplasty would be my choice in an older patient, and only because this person is only 28 years old, does that leave me hesitant about doing a total wrist arthroplasty.
Yeah, thank you. And also I'm curious about this kind of procedure you make. Of course, we see here that the 3D-dimensional analysis might be very beneficial. Without this kind of techniques, what actually would be options to do? Okay, let's say you wouldn't even have this kind of three-dimensional imaging at hand. So is this kind of thing possible to do on 2D native scan at all, or how do you feel?
I would feel that, well, I first did a series of regular CBCT scans, not using the kinematic analysis. And my feeling from that evaluation was that in parts of the carpal bones, it seemed to be fused. And in other parts, it looked like it was not fused. So I was left with this question as, is it fused enough to not be painful? Or is it a non-union that is causing pain? Because the pain was quite diffuse in this patient. So it could be that he had some synovitis, something else causing pain. So the kinematic analysis for me was absolutely the way to go to figure out that the non-union was the problem in this patient.
Okay, thank you very much. Then I think maybe we have a couple of more questions and try to stop at maybe in 5 minutes. So this question is for all of you. So whoever wants to have some insight on this, or maybe even all of you. So obviously all three of you are quite, I would say, you have used quite advanced techniques, maybe relative also related also to your peers. So have you found on this road, when you have been learning these kind of digital techniques, have you found any particular challenges or hurdles between until you have been able to utilize these kind of novel 3D modeling and analysis tools? So maybe Dr. Honigmann, do you have anything in mind?
Yeah, it was a rather long way to go, because first softwares were unaffordable, or are still unaffordable, I think. And these softwares are not easy to use, and you have to be technical wise experienced. As I said, segmentation. Who learns during studies how to segment a 3D model, and what problems occur if you use the wrong kernel reconstruction, for example. When you reconstruct, or when you want to go for an intra-articular corrective osteotomy, and you want to correct 2 or 3 millimeters, and you do the wrong segmentation, then you're doing the wrong procedure, and there's no beneficial. So you have to prove everything what you're doing, and that was a sort of developing, and lucky being a part of this research group helped me very much to identify the limits and the problems, and I think they are now all addressed in the software. That's why I'm using it on a daily routine now.
Okay, thank you. How about Dr. Waris? Have you found any specific problems, or maybe something which your colleagues are currently struggling with when discussing these 3D digital analysis?
Maybe one thing is that when I'm using patient-specific guides, you know, earlier I've done all these osteotomies manually, and I have trusted to myself. When you are using the guides, you have to trust that the guide is, you know, it's functioning, and it maybe takes time to, you know, trust them.
Yeah.
In the beginning.
Yeah, I see.
Because you just put this guide to the bone, and then you make those osteotomy lines, and then you put the plate in the end of the operation. You just trust to the engineer who has planned this guide.
I see. And Dr. Hagert, do you have anything to add maybe along this?
Yeah, I would say in my daily practice, I use the CBCT scan for doing just regular analysis of osteoarthritis, for instance, of the basal thumb joint or the wrist, looking for fractures, etc. Doing complex 3D analysis is something I do in the more difficult cases, such as this 4-corner fusion case, malunion of the distal radius, and having plan surgery. So it's the 3D analysis is not something I do every day. It's a little time consuming, but it's absolutely unbelievable when it comes to the complex cases, because those are the cases that you want to plan very thoroughly, so that you know once you start doing this quite advanced hand or wrist surgery, you're going to leave your patient with a happy result.
I see. And this actually, a little bit, my next question was about, in a way, what is the decisive factor whether you go with more traditional techniques or more these kind of digital planning tools and so on? So do you have intuitive, obvious intuition, like, okay, I will need these novel methods here, or this is routine and I just go along, or how obvious is that kind of decision to all of you? Maybe if this is the last question of the session, so we can end almost in schedule. If Dr. Honigmann, do you have any insight on how do you know when to do more advanced analysis?
In those complex cases, like Elisabet already said, it's I think something mandatory. You have to understand. I want to use it also, as I said, in the complex distal radius cases, but this is something you cannot have time consuming playing around with software in those cases. You have to have the results ready in some hours when you're approaching the OR, and it's rather impossible to print a guide. But for the analysis, I think it helped me a lot so far to analyze the key fragments in these complex fractures and complex malunions. As I said, mandatory. In easy malunions, it's also good to show the patient what is the problem. And it's the CT reconstructions, they are nice to play around, but the patient hasn't seen before. And then you have the quantitative analysis showing, listen, compared to your other side or compared to the standard values, there is a difference. And this is, I think this is a good point to use the 3D analysis. And for the scaphoid, we were searching for an easier way to handle the non-union intraoperatively, because it's sometimes a real hassle to open up the non-union and insert the graft, and that was the reason why we use this. But it doesn't have to be every case, of course.
I see. And Dr. Waris or Hagert, do you, of course, Dr. Hagert already kind of answered this, but if you have anything more to add, please.
I would say for my everyday cases with primary osteoarthritis, for instance, of the basal thumb joint or the wrist, I would not use the 3D kinematic analysis or do complex reconstructions, because those are the general cases where you have your routine surgeries that you do. Non-unions or malunions, and in particular distal radius or forearm fractures, I would say that this is mandatory.
Yeah. And Dr. Waris, maybe some final remarks before we end this session.
I think that in the beginning, you start to use this new technologies only in the more complex cases. But when you get used to it, you notice that how much it helps you. Then you take it, more in much more routine cases. It's much more easier to make many osteotomies, for example, if you're using some guides. Yes. Also in more simple cases.
Okay, thank you. I think now it's time to wrap up everything. So once more, I would like to thank all of you three for your excellent presentations. And I definitely think this is on the right track, at least on Disior perspective, we feel that way. But if this is something, all of this is something helping clinicians, then it's excellent. So for you and for all of in the audience, I wish good evening and end the webinar now. Bye-bye.
Thank you very
Bye,
much.
thank you.
Goodbye.